So you all mentioned anesthesia and them being concerned about having to watch the baby. Were there any other particular arguments that you heard from people who were resisting this from any part of staff, and how did you overcome that?
Yeah. The anesthesiologists are the most risk-averse physicians that I know. And so they know all the potential complications of everything and the case studies for which they happen and where they happen and what the dynamics of the case are. It's just who they are. It's the nature of their specialty. And the biggest thing had to do with the IV, because being able to have clear IV access and making sure that mom's blood pressure was maintained, because from a surgical point of view, you have to keep in mind that when we cut the uterus, there's a tremendous amount of bloodletting going on. And so as you slow that process down, you also increase the amount of blood loss in a procedure. And so that could have impacts on mom's blood pressure, which will have impacts on her sensation and how she experiences, because people get dizzy, lightheaded, they start to feel ill, they get nauseous. And in that situation, a lot of times moms want to hold their babies. They just want to feel better in that moment. And so anesthesia was mostly concerned about IVs and which side the IV was on, which side they were going to be on, so that they would have access to be able to give medication if necessary in that time. That was their biggest concern.
I did have one person in the OR team, it was a scrub nurse, say, if a person wants this kind of birth, why don't they just go to Women and Infants? And that's kind of a crushing moment for me, I will say. Women and Infants is a fine place to deliver babies, and there are people in the room here who deliver babies there. And I didn't, but what I said in return is that, we can do birth here too. We've been doing it for a lot of years, and and actually small places are the places to make this kind of change first in some ways. And so I was able to convince them to that, but that was kind of a crushing moment for me, because it was someone who's been there for 45 years and probably seen, I don't even know, 1,000 cesareans or something like that. But she turned out to like it. I mean, she turned out to, and that didn't stop us from doing it, but that kind of attitude, like, what if the patient had heard that? I mean, that's terrible. Like, and these are I think every little thing we say, this is somebody's birth experience. There's a lot of gravity in this situation, and little things like that are going to be heard. I hear moms all the time talking, when the providers were talking about the game on Saturday, that's what I remember of my birth. They were talking about the Red Sox game, and that's horrible. And so this was like that. If they'd heard I should have delivered somewhere else while they were delivering, I would have been, when someone that works there said that was really tough.
I would say there was more resistance from the OR staff, actually, than the anesthesiologist, which was surprising to me. And so part of it is that, I don't really understand this, but they thought it was icky, because, baby was slimy, and sometimes babies would have come out with meconium, and there'd be meconium all over the mom. They just thought it was icky. And I would never have a baby like that. I mean, these were women saying, ew, I didn't want that, so on and so on. So, everybody brings their own sort of sense of it. The other thing that I learned is that the mentality of someone who works in the OR is a lot different, because most of their patients, except for their C-section patients, are asleep. And they have total control. And I don't know about any of you, but I can venture to guess. I'm very, very control-oriented, and I imagine that some of you are. And when people start messing with your control, it makes you a little antsy. And so they would get antsy because you were playing with their senses of control and freedom. And it was a learning experience to really understand that and be able to talk to people about, and be able to reassure them that those things were okay. It's okay. This is how you can have your control in that scenario. I'm sorry, there was a question.
Oh, I just was wondering, I don't know of anybody else doing this anywhere else in Rhode Island.
I don't
Do you guys? I mean,
no,
somebody
I
said,
don't.
you should do this at Women, they should go to Women in Infants if they want this. That's not my experience, that anybody is getting this kind of attention and
I didn't say that to them at the
respect.
time,
Yeah.
because I didn't know that they weren't doing it there.
Yeah.
But that is true.
Yeah,
I
I
don't think they are.
think you guys are it.
Well, not only that, but I mean, many of you know, have heard my story, or read my story. My story's everywhere right now. But that I, went through 56 hours of labor, had a VBAC. 4 VBAC. Ended up with the gentle cesarean at Memorial, and there's a couple of things. I mean, first of all, you talk about control. Well, my reason for going to Memorial is because I wanted that control myself, and I'm a control freak. So, and I was able to have that there. At Women and Infants, I did not feel that I would have been able to go through 56 hours of labor, come to the decisions myself for each phase of that experience, or with a little bit of help from my two wonderful doctors, but and have that control. And then after that. Being able to have the birth that I wanted and still feel like I had the birth that I wanted, even though it didn't end exactly how I wanted it to end. So that was definitely something that I don't think I could have gotten at Women and Infants. And to have the two providers that I wanted at Women and Infants and be sure that they would be there when it would have happened. So
I think that's important. A lot of the providers there aren't taking like crazy amounts of, and we don't have big groups, because we're trying to be there for our patients. We take, and I have to turn patients away sometimes because I'll already have 3 patients through that month, and I can't guarantee that I'm going to be there, and that's why they're looking to me. So if I can't guarantee I'm going to be there, then I can't take them.
I really wanted to come today to see you guys because I see, everybody I see is mostly postpartum, and the worst thing for me is to see the moms that have had a C-section that have just been devastated by their experience. It is just heartbreaking for me. And it takes them a while to get over it, and I know why, and so I'm just so thrilled with what you guys are doing, and tell everybody, so that, because it makes a huge difference. It sets a whole tone for motherhood, I think.
And we cannot stress enough that we're doing it because you told us to. Like, we got this, we didn't one day say, wow, we should just be doing gentle cesarean. This came from patients and providers who were like, do you know about this out there, people? Like, you guys are the kind of people that could do this. And we were like, yeah, we are. We're the kind of people that could do this. And that started the whole thing. And then these, case examples that you brought up with Michelle Palmer. And so this came from you. So the more feedback you can give us about what was good and what wasn't good about it, that changing it, making it better, the wedge thing, I'm all over that now after reading this blog. If I didn't have to do this talk for you all today, I wouldn't have even known to read about that, because there's so many things to read about. I take care of high-risk pregnancies. There's all this new stuff about preeclampsia I'm also reading about, so, yeah.
I have a question. This is the second time I've now heard of this. The lotus birth. Yeah. I had a midwife mention it to me, and she was saying that the risk of the lotus birth, and my understanding that the placenta is still attached after birth, and the risk to the baby is if the placenta is dropped below the baby, they can get anemic.
Yeah. Well, they can get backward flow through the cord.
So it can be a risky thing to do, no?
Well, no, that's so hard to say. Who lets the placenta drop to the floor? I think, yes and no. Right. I think it's actually probably in some ways easier in a cesarean. I hate to say that, but you could just put a Mayo stand, which is where those extra stands on the side, you just put it at the level of the mom's shoulder, and there it would be. It would probably be easier there than it even would in a vaginal delivery where mom has complete control of where she moves and might forget about the attachment and all of that.
What's the point of that?
What's the point of it? I don't know a ton about the physiology of a lotus birth. I think a lot of it is because it's sort of, I think it takes the physiology of delayed cord clamping a step further, that there may be no medical reason to clamp the cord at the time we clamp it. And once it stops pulsating, we always say, we'll clamp and cut at that point to prevent reverse flow. But if you have it level, you're not going to have reverse flow. And there may be people in the audience who are more of a lotus expert than I am. I just know I can do it safely, and if people want it, I'll do it. But I haven't.
How long do you leave that attached for a lotus?
Till it falls
off. The idea of it is that
the longest I heard was 10 days, by the way, which makes no. I can't believe it was that long. But have you longer than that? No. Yeah, 10 days.
So
is the
until the
longest
cord
I've heard
falls
staying
off?
attached. It falls off.
And so you just carry it around the house with you?
Yeah.
Sure.
Yeah. We put it in a biohazard bag, actually, to leave the hospital, because that's the hospital's rules. So poor baby has a twin of a biohazard bag attached to it, which I recommend you immediately remove when you get to your house. But in the car seat with the baby, it's there. It's attached the whole time. So, yeah. There's a lot of people.
I don't have anything about lotus birth. I think actually, instead of me talking to Tracy, she's our person.
Yeah, that's right.
That would be great.
Typically with a lotus birth, the cord will actually fall off sooner than had it been clamped. It's more, and religiously.
You mean the stub of the cord?
The stub.
It takes longer to fall off than if you have a lotus birth. That
right.
would be faster. Yeah, that makes sense.
And spiritually, they see it as, the second sibling, and that it should fall off when it wants to fall off. It's just more natural.
I have a question about the mentioning the reverse flow. And if the court is closing up, from what I've read, closing up from the baby's end, that the baby is in charge of that, then how much can flow back in? Anyway?
Not much. Like, not enough to even, I mean, I could imagine that once it's stopped pulsating, that you could hold it way above. It's not gonna it's not like a funnel where it's just gonna drip back into the baby. But I think that's the fear, and it's quite understudied in terms of what is actually happening, because I don't think it's been very well studied. But there's certainly no evidence that it's not that it's unsafe in any way.
Right.
And so I think it's really rare to want it. I'm glad that there's experts in the audience that I could actually get in touch with if I needed to. I've only actually done it once, and I've had folks who had very entailed birth plans, but this is something that they've only designed. I've had people millions of people take their, not millions, but take their placenta home. That we've done, that seems like, I would say that's 1 in 5 for me these days, is people taking the placenta home. But leaving it attached is pretty rare.
Yeah, I've done logistics for it in the hospital.
Yeah.
That's fun.
Oh yeah.
Does that really freak out the nurses?
Oh, big time. We hand select your nurses for your entire hospital stay. No, you can't round on my patient tomorrow. I will be going there.
I actually have 2 questions. One, could you tell us a little bit about your practice, where it's located, and I know that maybe I'm wrong, that you're do some things with Mary Bailey, does that make sense? So can you tell a little bit about that, and also I was curious where you went to med school. And my other question is, people say over and over again that VBAC is a better choice, than a C-section because of risk of infection, blood loss, and whatsoever. But why is it that malpractice insurance makes it so high? Why is it such a difficult thing to convince providers and hospitals to allow VBAC? There's only 2 hospitals in Rhode Island that do it. So why is this the safer option yet? Why is it more litigious, circumstance to be around?
Well, there's so much there. We could talk for an hour about the malpractice nature of it. C-section is done extremely safely from a operation complication point of view. The overall complication rate for C-section is very low now, so it's considered to be, compared to other major